Good afternoon, everyone. A very warm welcome to the CPC today. It's my privilege to introduce our esteemed clinical discussant for the day. She is Dr. Nisha Singh, Professor and Head of Department, Oncology at King George Medical University, Lucknow. Ma'am is a distinguished expert in the field of gynecological oncology and with a keen interest in preventive oncology, minimally invasive surgeries, and hereditary gynecological cancer. She has played a pivotal role in establishing hereditary cancer and surveillance clinic at KGMU. She has also been instrumental in developing gynecologic oncology training modules for UP government. Ma'am is an alumni of Lady Harding Medical College and a postgraduate from AIIMS New Delhi and has numerous fellowships to her credit. She has outstanding contributions in gynecology with more than 100 publications, 20 book chapters, and 23 research projects. Beyond her academic and clinical endeavors, Ma'am is also Vice President of Association of Gynecologic Oncology of India and Vice President to UP State Chapter of AGOI and also Vice President of AOGIN India. I welcome you back, Ma'am, to AIIMS. Yeah, you may please come on the dais and start the discussion. Thank you.
Thank you, Dr. Ruchi, and a very good afternoon to all of you. It's a nostalgic moment for me standing here where I left AIIMS in 2001 January actually, and after my PG and SRship. So presenting this clinico-pathological case today. So this is a 65-year-old postmenopausal woman from Haryana, and she has come with a history of discharge per vaginum for 3 months. That's the only complaint that she has. She was asymptomatic for last 3 months, 3 months ago, and then she started having this problem. It was a watery discharge, not foul smelling. It was staining the undergarments, and it was intermittent in frequency, not associated with any bleeding that is an important component of the history. There was no associated fever, abdominal pain, or distension, burning micturition, increased frequency. There was no history of hormonal pill intake. And then she consulted a doctor with these complaints and was advised to get an ultrasound. And this ultrasound revealed some lesion in the uterus, and subsequently she self-referred herself to AIIMS. Now, examination findings by the local doctor are missing. Mostly people jump to investigations. Whenever we get such a case, it's just good to see their papers and see what were the clinical findings at that time. So some more points that I feel could be added when you are taking a history of such a case. Is there any urethral pain, hematuria, urinary incontinence, which may suggest some signs of atrophic vaginitis or menopausal symptoms that could be there, when vulvovaginal dryness, pruritus, dyspareunia, any lesions in the external genitalia that she feels if she can palpate, or then postcoital bleeding, if any, because there's no associated history of bleeding, but postcoital bleeding separately has to be asked. Any history of any mass coming out per vaginum is also important, because sometimes it may be just a prolapse with a decubitus ulcer, which is actually causing this discharge. History of loss of weight or loss of appetite is important, usually associated with malignancies or some chronic illnesses that may be there. Any history of cough or hemoptysis should be asked. It may be one of the signs of advanced disease with metastatic lesions elsewhere, because she is a postmenopausal woman and we must be considering some of the genital tract malignancies. Any change in bowel habits, any high-risk behavior in the patient or in the husband, which may be directing towards infections other than HPV, HIV or anything. Now, in her obstetric history, she is a para 3 with live 2, all full-term normal vaginal deliveries. Last childbirth was 30 years back. There's no history of oral contraceptive use or intrauterine contraceptive device insertion. There is no history of tubal ligation. So the points that could be added, is there any history, although she is a multiparous woman, at any point of time or in the beginning of her marital life, has she had any history of infertility for which she got treated or something? Because nulliparity is a risk factor for CA endometrium, multiparity is a risk factor for CA cervix. Intake of OCP is a protective factor for CA endometrium. So these things should also be asked in addition. Now, in the menstrual history, she had menarche at 15 years and she's menopausal for 10 years. So if she's 65, it was at 55. So if you see, it's kind of a early menarche and a little late, not early menarche for today, for this time, but a little late menarche, of course. So it is a risk factor for C endometrium. The perimenopausal transition was smooth, no prior history of postmenopausal bleeding, and prior cycles were all regular. Then a history which could suggest PCOS, like weight gain in the adolescence or reproductive age group, and maybe helping, because those are also risk factors for endometrial carcinoma. Any history of hormone intake, although said not there, so that is important as a risk factor for C endometrium again. Now, in the past history, there is a history of laparoscopic cholecystectomy 12 years back. She was diagnosed with hypertension for past 3 months and she is taking some medicines for that. There's no history of diabetes, hypothyroidism or hyperthyroidism, tuberculosis or any prior malignancy. So one should ask about the compliance, whether the patient is taking her medication, is the blood pressure controlled or not, just as she understands about it. And as we have said before also, we should remember this corpus cancer syndrome where obesity, hypertension, diabetes are, this triad is a risk factor for C endometrium, and she has obesity we will see once we see the height and weight and the BMI, and there is hypertension which we can see now. The family history, there is no history of any malignancy in the family. Points that need to be added. Now, these patients just asking that whether there was a malignancy, we can ask direct leading questions for the possible malignancies that we are thinking about. A pedigree chart should always be made in these patients, and so that you can talk about specifically about ovarian, colonic, endometrial, prostate or breast carcinoma, which may have hereditary components in these patients. History of tuberculosis or any chronic disease in the family should also be ruled out. So as I said about the particular cancers, you can understand that we are hinting towards the BRCA1, BRCA2, genetic mutations leading to HBOC, hereditary breast ovarian cancer syndrome, or the Lynch syndrome, or maybe rarely a Cowden syndrome also, which may be there. Personal history, normal sleep phase cycles and no history of any addiction or allergy. Dietary history has just been missed, though not very related to a particular, but then for an overall evaluation, it is important to take the dietary history also. So based on the history, we should try to make up one diagnosis first, and it should be as wide as possible, whatever we can think about based on whatever points have come by now. So what we understand, she's a 65-year-old menopausal lady with discharge per vaginum with chronic hypertension with history of cholecystectomy. So with this, the possible, because there is this discharge and the age, cervical cancer, although there is no postcoital bleeding, there is no bleeding per vaginum, but endocervical carcinomas may sometimes present just with discharge. There could be CA endometrium, which is the next here at this point of time. There could be a cervical polyp, there could be an endometrial polyp also, which is just producing this discharge. Submucous fibroid, rarely, because mostly when there is a menopausal woman, we don't think about that, but then, yes, sometimes they may be there. And last of all, once all of them will be excluded, it will be an atrophic vaginitis or cervicitis, which is leading to some kind of discharge. So when the examination of the patient is done, we are able to narrow down our differentials, rule out certain more things out of all these. So she was ECOG performance score 0, alert, conscious woman, and well-oriented to time, place, and person with GC fair, hydration adequate. Her vitals are normal, respiratory all normal. Height and weight suggest a BMI of 30, which is now going high. So she is now added, has got one more risk factor if you think about endometrial cancer. Pallor, icterus, cyanosis, all this is absent. Thyroid, breast normal. Systemic examination, CVS, respiratory, all normal. So we just found one more risk factor in this much examination. When the Abdominal examination is done. Apart from obesity, I think rest everything is normal. And there is no mass palpable, nothing, but question, there is just a tympanic sound, there are no bowel sounds. Just wanted to add that because there is obesity, sometimes you may miss any ascites. So if clinically not palpable, shifting dullness can be tried in these cases, and we should try to rule that out, at least on clinic. Now coming to the local examination, external genitalia normal, healthy looking most probably. First speculum is important. The cervix is congested and flushed with vagina. Vagina otherwise is normal. On PV examination, cervix was flushed, regular, no growth palpable, and uterus is retroverted, mentioned as bulky. Fornix is free, non-tender. Per rectal examination is important. Rectal mucosa is free and bilateral parametria. Now, when we do an examination, because the chief complaint was discharge, it should be mentioned whether that discharge is seen at that time of examination or not, and what is the kind of discharge if you are seeing one. Comment on bleeding if it is present at the time of examination, whether your fingers get stained with the gloves get stained with the blood. The cervical size is also important. Sometimes there is a ballooning of the cervix, which may be just appreciated by palpating when you do a PV examination. So is there any ballooning of the cervix? And comment on the size of the uterus. Now, when we say bulky, as clinicians, as gynecologists, we talk in terms of weeks of pregnancy, the size of uterus usually. Radiologist, of course, anything that is more than normal is commented upon as bulky. But clinically, we say bulky only when it is somewhere between the normal and 6 weeks. It's a smaller one. It's once it is 6 plus, then we usually talk in terms of how many size weeks is it corresponding to the pregnant uterus, something like that. And then comments on any nodularity thickening present in the pouch of Douglas is also important. So after the history and examination together, what do we find that, so if I say that it is that bulky uterus, that it is less than 6 week size, so it is just slightly enlarged. So here my diagnosis, the differentials that remain now are, now C endometrium becomes little more, comes on the first because cervix appears absolutely normal. There may be an endometrial hyperplasia also. There may be endometrial stromal sarcoma, things that can just be picked up by pathologists, not by us clearly. It still can be an endocervical carcinoma extending up into the uterine body, the growth extending. Cervical polyp, endometrial polyp, still somewhere inside, and submucous fibroid. I still don't remove it from my DDs. Now, coming to the investigations. So you got all these blood workup that appears all normal, the CBC, and then the, yeah, everything is normal. TSH, urine culture, yeah. Now, HPV DNA test has been done probably as a, like for any case, you must do a screening because you're not seeing any clear-cut growth. So it was done and it was negative. And then a colposcopy has been done, which is a type 2 transformation zone, sweet score of 7/10, and cervical biopsy has been taken. And bilateral breast mammogram also has been done, maybe as a routine, but anyways, it is a BIRADS 2 in the right side, left side it is BIRADS 1. I would just say that if there is a discharge, that should also be sent for culture sensitivity. If there is, that's one. And I don't know with HPV DNA negative, if one screen is negative, colposcopy is really indicated or not, but whatever it is, once it is a cervix is flushed, as it is, it won't always be a satisfactory colposcopy because you won't be able to see it properly. Anyways, but it was done and it was found to be, once it is a SWADE of 7, then biopsy has been taken, that will be done. Then an imaging has been done and the ultrasound. Now see the ultrasound. The uterus is anteverted, bulky. As I said, radiologists will always call it bulky whenever more than normal. And then it is 11.4 into 4.3 into 6.5. Now this is, and the cervix is also bulky, and there's a heterogeneous mass of 2.1 into 2.6 centimeters involving the lower uterine cavity and filling there is fluid in the upper endometrial cavity. With this, I don't have the picture of the ultrasound, but I feel that the uterus is bigger 11 centimeter means about 10 week size. It's a bigger uterus. And that's what I felt, that clinically they do not correlate. Cervix also is bulky here and probably not appreciable clinically. And what was recommended is an endometrial aspiration, endometrial biopsy with ECC. Here, I particularly feel that when you are seeing a mass or a growth and you are not very, so maybe a hysteroscopic guided could also be done. Now, this I will come to again. Coming to the imaging, another imaging, that is MRI, which has been done. Now, MRI, the uterine size is different. It's 4.5 into 5.5 into 7.2. So it looks smaller now. And then the endometrial thickness is 12 mm. And the endometrial myometrial junction is maintained. And now they are seeing a pedunculated lesion which appears 10 into 4 into 0.8 centimeters. So that is like, yeah, it's a 4 centimeter long, yes, and 1 centimeter broad and about 8 centimeter, so that's how it is. It's a long structure that is there somewhere. Arising from the posterior lateral endometrial wall in upper uterine segment, prolapsing through the distended endocervical canal. So it is coming into the endocervical canal, showing intermediate signal intensity. I think we'll have the radiologist afterwards, so we'll listen more from them. But when, as clinicians, we see such reports, I just wanted to highlight that the ultrasound and the MRI size of the uterus appear different. The MRI size is corresponding with the clinical size, not the ultrasound size. That was one. And thickened ET that is there, it can be suggestive of the polyp stalk or maybe a pyometra collection that is there. And there was no cervical ballooning in the clinical, but in both the ultrasound as well as this thing, we are finding it in the lower uterine segment. So with these findings, these two slides I had just put up, maybe, yeah, I'm not discussing that. You want it now? Yeah,
she can come and just describe without giving
all right, okay, please. I think, okay, come.
So these are the T2 sagittal weighted images of the MR pelvis. And we can see that this is the uterus. So this is the endometrial cavity. And we can identify that there is a mass lesion which is T2 hypointense, which is extending into the cavity. And the entire cavity is also distended with contents which are intermediate signal. So the normal signal of the endometrial cavity should be this bright, that is this hyperintense. So the entire cavity is distended with contents which are intermediate signal. Apart from that, this is this linear T2 hypointense stalk-like lesion which is extending from the myometrium into the endometrial cavity and further into the endocervical canal. So this part is the endocervical canal. In the upper part of the endocervical canal, also there is extension of this mass lesion. The mass lesion appears to have a signal which is intermediate, and there is also thickening of the junctional zone and an altered signal of the myometrium per se. So as we see in the parasternal sections, the normal signal intensity of the myometrium is not well appreciated. There is an altered signal which is, the normal signal should be this T2 intermediate and this T2 hypointense should be the junctional zone. But the entire myometrium appears to be of an intermediate signal. These are the T2 fat images where we can see that the bilateral ovaries appear to be normal for the postmenopausal age. These are the sections of the uterus where we can identify that this is a T2 hypointense lesion within the myometrium on the right side. This is the intermediate signal which is appearing abnormal. And as we go inferiorly, we can see that this is the endometrial cavity which is again distended by that mass lesion which also has a T2 hypointense stalk to it. These are the T1 weighted images which do not add much to the lesion description except that there are no significant lymph nodes. And this is the coronal T2 weighted image again where we can appreciate the altered signal of the myometrium and this content within the cavity. We have a whole abdomen MR coronal sequence where we can see that the bilateral kidneys are appearing normal. There is no definite evidence of any hydrourethral nephrosis. There are no periportal or peripancreatic lymph nodes, and there are no significant para-aortic lymphadenopathy. So now in terms of description, that is all that we have on the images. We do not have a contrast imaging and we do not have a diffusion weighted imaging. So there is a lesion within the endometrial cavity which is intermediate signal. Now an intermediate signal or in the endometrial cavity is more suspicious for malignancy as compared to a benign polyp. The morphology is appearing like a polyp because it has a T2 hypointense stalk which is extending from the myometrium into the endometrium. So our differential would be that there is a lesion which is there within the myometrium as well as in the endometrial cavity. Because of its intermediate signal on the T2, it is more likely to be malignant, however difficult to characterize without the diffusion or the post-contrast images. So in a large uterus with a thickened endometrium distended with a T2 intermediate signal intensity mass lesion with linear internal T2 hyperintensity suggestive of a stalk, lesion extending into the upper canal, junction zone irregular, similar altered T2 signal intensity seen in the anterior and posterior myometrium, more marked along the right lateral aspect, no evidence of ascites or significant lymphadenopathy, possibly a malignant etiology, could represent an endometrial stromal sarcoma or carcinoma sarcoma more over an endometrial carcinoma, primarily because of the altered signal of the myometrium.
So thank you so much. I'll just finish off. So now that we have the history examination and also the investigation reports that we have, so a 65-year-old menopausal woman with an endometrial growth, chronic hypertension, obesity, grade 1, and history of polycystectomy and differentials. Now, putting all that together, so with imaging, it is more likely endometrial carcinoma. With age, also, it is the triad. Out of that, we have obesity, we have hypertension, and of course, the look is like an endometrial polyp. So I have put up as a second this thing still because that myometrial lesions were not very clearly mentioned in the report that was there. Among some of the very rare things I have just put up, sometimes that you can get things like lymphomas, sarcoidosis, or placental site trophoblastic tumor. Very, very, very rare. And then metastatic lesions from elsewhere. This is just overall when you are seeing a case, you should not. So cervix coming to endometrium or from ovary, here ovaries were completely normal, breast was normal. But then these are the sites from where it can. So if you see, you should exclude those also. And as we said, here with all this rarer histological types of C endometrium are not quite likely actually the carcinoma sarcoma and endometrial stromal sarcoma or uterine adenosarcoma. That is with this, the reports are awaited, the cervical biopsy and also the ECC and endometrial. The only thing is when they do endometrial biopsy, because what I was mentioning as just to why I was mentioning about hysteroscopic guided, whenever there is a polyp-like or this kind of, it is better to go and take out that thing and then send, so you get a bigger tissue. That's one. Second, rather, the first is, if it was only a polyp, it becomes both diagnostic therapeutic in the same go, if it is just a polyp, because many times you take the biopsy in a polyp and it will be normal, but the patient keeps bleeding, you have to go back again and then do the hysteroscopy and then do the removal. So that was just a point in case it is a benign, in cases when it is a benign. That's from my side. Thank you.
You can narrow down some top two different.
So now in this case,
Can
it
you
is CA.
Yeah.
What I have put up as the endometrial pathology, CA, hyperplasia, or sarcoma, I mean, they are all in one. And then a polyp that was there before, I didn't hear from the, because radiology, the myometrial involvement was not very clear in the report. So that's what I had prepared. If we add that, then of course it goes then towards malignancy only.
I would like to invite any thoughts from the audience. If you would like to ask anything from ma'am.
Any questions?
Anybody has any differentials to offer?
So with that, we now proceed to invite our teacher.
mentioned in imaging, see that diagnosis of the lower segment of polypoidal mass, right? The lower segment. That should be indivisible power, like poly or others. It could have been a bit more on top.
Yeah, it's okay. I put it this side as types of dose.
But in this kind of patient should not present a bleeding and just polypoidal mass on there. And also the appearance of the mass, it looks like it had more of a appearance like myomectomy rather than that's a sarcoma. Yeah. So imaging wise also it appeared.
But the center region was dominant
In the
infiltrated, or was it in the endometrium? Endometrium. But myometrium is also myometrium. Yes,
But the polypoidal the appearance was more like myomectomy. And usually the endometrial carcinomas, they would have some kind of a presentation before they reach the side. They should have some total or bleeding or something. She is presenting only the discharge. That is also another very important point. Why is she presenting the discharge? Because the endometrium will not present the discharge.
See, endometrium or neomyosarcoma is very similar, and that I don't see as very different.
Sarcoma is the discharge.
Any of the residents who make to come up with what's those of you who hear about that thing. Like a, this is like a, for CPC is meant for this only. You have to speak up.
We don't have any report as yet.
Some information has been given. Basically, if you have any problem based on the imaging, you have and the presentation.
So, like the cervical, the what we saw the score of 7 score. I mean that can be in addition to the endometrial pathology. To try to club it, it is right difficult. Separately, yeah.
Thank you, ma'am. I would like to invite Dr. Jyoti Meena for discussing how the case was managed.
Thank you, Ruchi. So this was a patient who presented to us at NCI Jhajjar OPD. She's 65-year-old and with a history of only discharge PV, which was non-foul smelling watery. So initially, when it was seen, we saw that the cervix was completely flushed but congested. However, on examination, no discharge was mentioned. There was no discharge at that point of time. And on PV, we found that cervix was completely flushed. It was not ballooned up, but the uterus was bulky as compared to 65-year-old, 10-year menopausal. It was bulky. So the disease which came to our mind initially, we thought it can be CA cervix also, maybe an endocervical carcinoma, or it can be endometrial hyperplasia with polyp, or can be an endometrial carcinoma. So when we proceeded with the investigation and the report came, the disease which we thought initially were, it can be an endometrial hyperplasia with an endometrial polyp, it can be endometrial carcinoma or even sarcomas also. And we also kept the DD of endocervical carcinoma because the lesion was extending till the cervix, and a rare possibility of just pyometry also. But after imaging, that was ruled out. So we proceeded because she had cervix was congested and she had persistent history of discharge. We thought to take HPV DNA, and we did simultaneously colposcopy also. So the colposcopy came out to be, suite came out to be 7/10, and we took an cervical biopsy and also took an endometrial biopsy, EA plus ECC. And based on the report of EA ECC, we further proceeded with surgical management for this patient. And for the histopathology point, I will call Ruchi ki how.
Thank you, ma'am.
First,
So, after the very nice discussion of the case, I would like to now start with what we received. What we received was an EA and ECC of this 65-year-old female who presented with postmenopausal discharge. And ultrasound details was provided as the uterus was bulky and there was a growth of 2.1 by 2 centimeters in the uterine cavity. So this is the first image taken from the EA. If you see here, this is an unremarkable marginal tissue. The biopsy was fragmented. It was having areas of hemorrhage, and this was the tumor tissue. Going on high power, the tumor was comprising of tumor cells, which were in the form of cords and tuberculae, having in a very Hylian kind of a matrix. There was mild to moderate atypia, and few mitotic figures were also seen on this section. There was focal necrosis, and the tumor, there was only focal necrosis, the mitosis was not very brisk so far. So with this in mind, the tumor cells had pleomorphic nuclei, hyperchromatic nuclei with vesicular chromatin, inconspicuous nuclei, and an occasional mitosis. So on this picture, we were also in a dilemma of an epithelial malignancy or a mesenchymal malignancy. We thought of a carcinosarcoma, thinking that it could be a mesenchymal part of a carcinoma, since it had no glands or papillae or anything to suggest a carcinoma in this. And the other differential was some kind of a mesenchymal tumor, a sarcoma possibly. But this was also not a classical picture of an endometrial stromal sarcoma. So we did IHC markers. Our first marker, PAC8, came out to be very nicely positive. But to confuse us all, pan-cytokeratin was negative, EMA was negative, E-cadherin also was cytoplasmic, which means it was negative. In an epithelial malignancy, it shows membranous positivity. BRG INI was retained in this tumor. P53 was wild type. ER and PR were negative. So with this, and after this, we also, since only PAC8 was coming positive, the cytokeratin was negative, EMA was negative, and hormonal markers were negative, we thought we should also rule out a sarcoma. We did a CD10. CD10 was positive, very nicely positive, as you can see in this image. So on this aspirate, we gave a differential of carcinosarcoma / an endometrial sarcoma on this biopsy. Further, we could rule out undifferentiated carcinoma because at least it was showing PAC8 and CD10 positivity. High-grade carcinoma was as such ruled out. So with these possibilities, we received a specimen of total abdominal hysterectomy with bilateral salpingolectomy and infrapolymentectomy, right and left pelvic lymph nodes and paraortic lymph nodes were received. So this is the picture of the specimen that we received. As you can see here, this was a very polypoidal kind of a growth filling the endometrial cavity. And this is the myometrium, it is compressing the myometrium, it was well circumscribed, there was a stalk in this, but there was no area of hemorrhage or necrosis in this tumor. It was measuring around 4 by 3 centimeters, and it was not extending into it was not showing any myometrial invasion as such, or any serosal deposits, or the adnexa was free. The cervix was also free for that matter. This was the sections from the surrounding endometrium, which was showing a nice atrophic endometrium. The atrophic, on the right side, if you see, the endometrium had some surface metaplasia, tubal in the form of tubular squamous. Now, this picture shows the tumor was polypoidal, and this is the myometrial and the tumor junction. So, this was a very well circumscribed kind of a growth. There was no infiltrative tongue-like projections into the myometrium so far. And the polyp was arising from the myometrium because it was covered with the same surface lining, metaplastic surface lining, as was seen in the endometrium as well. On microscopy, the tumor morphology was similar to what we had seen in EA. There was no other areas. In fact, there was no necrosis in this specimen. There was no hemorrhage, no infiltration into the surrounding medium, into the surrounding myometrium, and no obvious benign or malignant glands to suggest a possibility of adenosarcoma or a carcinosarcoma in this. The cells were again in cords and trabeculae with moderate pleomorphism. Mitosis here was 3 to 5 per 10 high power field. On EA, the tumor was, so till now the tumor was positive for, on the EA we know the tumor was positive for Paxate and CD10 and negative for EMA, CK, ERPR, P53 was wild type, E-cadherin was negative. So with this, to start with in the specimen, now our differentials were more in favor of a sarcoma over a carcinoma. A carcinosarcoma was less likely still. In carcinoma, is the first differential that comes into our mind looking at the picture was a low-grade endometriostomal sarcoma. But because it was showing mitosis also, and there was focal necrosis in the EA, so a high-grade ESS was also thought of. Sometimes an epithelioid leiomyosarcoma can also look like this. An epithelioid, and then other miscellaneous mesenchymal tumors, utrost or picomas. They were very low down in the list. Now, just to confirm, we did a pan-CK again. If you see, the internal control was positive here. The internal control was positive. The tumor was very nicely negative for pan-CK again. Then we did SMA Desmin next. SMA, this is the internal control. Our tumor was totally negative for SMA. It was positive for Desmin as confirmed by the internal control. It was negative for ESS. We did a BCOR and cyclin D1. BCOR was negative. Cyclin D1 was nicely positive. So we thought of high grade ESS and we went for fish. So on fish, YWHA BCOR was negative. This is the break apart probe which is not showing any positivity. Similarly, we also ruled out low grade ESS by doing JAZ-F1 SUS12 fish, which was negative. This probe is the fusion probe, which is not showing any fusion anywhere in this picture. So both of these DDs were now ruled out. So now so far we had we are thinking of a sarcoma, and ESS low grade and high grade have been ruled out. So now we thought we should be more towards a miscellaneous mesenchymal kind of a tumor. So two DDs that come to our mind were a utrost or a picoma. For picoma, HMB45 and Milan A were negative. Then we went for utrost. We did some sex cord stromal markers. FOXL2 was nuclear positive in this. There was focal positivity for calretinin, but it was negative for inhibin. WT1, however, was strong, but it was cytoplasmic. WT1 nuclear is also a marker for sex cord lineage of cells, but in this case, it was coming cytoplasmic. So to explain the markers so far, FOXL2 is a sensitive marker for sex cord cells, and WT1 cytoplasmic positivity indicates a myogenic differentiation. So now we are looking at a tumor which has polyphenotypic kind of expression, a Mullerian epithelial differentiation as was suggested by Paxate positivity on the EA, a mesenchymal myogenic differentiation as was suggested by Desmin and cytoplasmic positivity WT1, and a sex cord stromal FOXL2 and focal calretinin were positive. So with this, keeping this picture in mind, our final diagnosis was uterine tumor resembling ovarian sex cord tumor in this case, which was difficult to arrive at even for the pathologist, I agree. Now, something about utrost. Utrost was first described in 1976 by Clement and Scully. These are rare tumors of the uterus, less than 1%. They were initially described into two types. Type 1 was endometrial stromal tumors with sex cord-like elements, and type 2 were uterine tumors with predominant sex cord element. Usually, these are usually low-grade tumors. Now, in 2014, WHO, what they did was they took this category of type 1 and included in endometrial stromal sarcomas. And now what utrost it is a separate category in the WHO classification of tumors. So in 2020, currently, this is the classification for mesenchymal tumors of the uterus. We see that uterus enjoys a separate entity and under the name of miscellaneous mesenchymal tumors. Now, these are defined as uterine neoplasms with morphological patterns that resemble those seen in ovarian sex cord tumors without the component of endometrial stroma. These are seen in adult peri or postmenopausal women, usually third to sixth decade, mean age is 50 years. Clinical presentation can be abnormal uterine bleeding, pain, abdomen. These are even asymptomatic or incidentally discovered. So this is a series of cases which I have put it because to show that these tumors are usually they are intramural or submucosal or also polypoidal masses. So in polypoidal masses, I think it is very rare though, but can be kept in DDs. The average size of this tumor is 6 centimeters. It has well circumscribed margins. The cut surface of this tumor was just like in our case, solid, soft to firm, yellow to tan cut surface. This is the data which has been published from our institute. We had 6 cases earlier up to 2018. In those cases, there was no recurrence, only one case reported recurrence. So the this tumor has varied morphological patterns. Even for a pathologist, it is not a first diagnosis. It can show, because it can show these tubules or sheets kind of a structure, or it can show in cords like the tumor we had was showing. Even had foamy cells can be there. The nuclei are ovoid. They have minimal cytological atypia. Mitotic activity is low, except if the tumor is undergoing malignant transformation. Then vascular invasion may be seen occasionally. In our case, we did not see any lymphovascular invasion or infiltration into the myometrium or any lymph nodes. This is from our study. We had these kind of patterns. It can be in sheets, and this is somewhat like our. It has abundant matrix, and okay. Now coming into the pathogenesis, they are thought to arise from pluripotent mesenchymal, endometrial stromal, or displaced ovarian sex cord cells. So probably that is the reason that they are polyphenotypic. They can express epithelial or mesenchymal or they express sex cord stromal markers. So if there is one tumor which can express any of these markers, it is this uterus. The exact pathogenesis for these tumors, however, is still unknown. They have now studied it through molecular profiles, and they have come up with, they've seen that rearrangements involving ESR1 or GRED1 have been reported in these, with the partner usually which are NCO-A, NCO-A2, A1, A2 and A3. However, these tumors do not express JASF1, SUS12 fusions, and for FOXL2 alterations, there have been literature which says that FOXL2 will be positive on IMC, but the alterations are not found in these tumors. So these are polyphenotypic immunohistochemical profile. As I told you, they can have variable positivity for sex cord markers, epithelial markers, or smooth muscle markers, as was also seen in our case. Now, they are mostly benign, but WHO says that they should be considered as tumors of uncertain malignant potential, because cases with aggressive behavior or metastasis have been reported. However, there is no definite histopathological criteria which can say or predict the behavior of these tumors. In this review of 80 cases, there are a few more studies like that where they have said that age, menopausal status, tumor diameter, or number of lesions, infiltration into the myometrium, atypia, mitosis. These are all insignificant when it comes to disease-free survival. The only thing which was significant was organ-preserving surgery. So they say if you do a complete hysterectomy, the chances of recurrence are very low. So that has a better patients with total hysterectomy have better chances of survival. Then, and also one thing more with the recent molecular updates coming up, it is seen that GRED1 NCOA fusions, these tumors which have GRED1 NCOA2 fusions have a higher recurrence rate. These tumors are staged as per staging by FIGO or AJCC. According to the uterine sarcoma guidelines. With this, I conclude my case, and these are the references. Thank you. Now, I invite Dr. Jyoti ma'am to discuss the further management of this case.
So after the biopsy, cervical biopsy in AACC, the report which we received was, in the cervical biopsy, it came out to be low LSIL, that is low-grade squamous intraepithelial lesion, and in EA, they commented query carcinosarcoma. So with this, we proceeded with the staging laparoscopy. We did the peritoneal wash cytology and total extrafacial hysterectomy, bilateral salpingocorectomy, intracolic omentectomy, and bilateral pelvic and para-aortic lymphadenectomy. So these were the intra findings. So uterus was around 6 weeks and it was completely filled with this polypoidal growth, and the momentum was adhered to the anti-abdominal wall also, and it was so an infracolic omentectomy was also done, and along with the pelvic and the para-aortic. So patient, she had an uneventful post-operative period and was discharged on post-operative day 3. And the final histopath which came out to be was a diagnosis of uterus, which was stage 1A1. So we had a discussion with our medical and radiation oncology team, and she was kept on follow-up because as there was no other evidence of any metastatic or advanced disease. And currently the patient is under 3-monthly follow-up and is doing well. Thank you.
From the Department of Pathology, I would like to really thank Dr. Nisha for having so wonderfully discussed this case. I don't think it's possible to clinically arrive at this diagnosis because it's, even for the pathologist, it's a fairly complicated diagnosis. So I must congratulate ma'am for having an excellent discussion on this case, and she deserves a round of applause. That's what CPC is about. It is about the clinical approach, learning, and differential diagnosis. So whatever be the final diagnosis doesn't really matter much. And thank you to all the clinical colleagues who helped this case. And thank you, Ruchi. And I must like to mention that the very first, my first experience with this, I remember Dr. there was one neurosurgery son whose mother had a CA endometriosis. So उसकी मतलब ये भेजा हुआ था. That year we were looking at it, it's very real. No, nothing like a carcinoma endometrium which we were expecting. We were scratching our head, options should be slightly. So that time we never had specialized. We had even not said that secondly. It came in, sir, but since I had interest in Gynecological, even that, so he showed me this case and we discussed. Ultimately, honestly, I admit, the first time I never made to make it. It was Ruchi Sharma who made the first diagnosis from our department. And following that, we have been able to pick up this that experience. Yes, 5-6 cases and we published Dr. Nirni. It was also
Basically, the IC or morphology.
Morphology.
What is the diagnosis?
morphology is very
Morphology,
important.
what exactly?
Yeah, so because it being such a rare tumor, it is, if somebody is not seen, it will not take it up in the first place. That's what happened with the first step. The morphology में यही जो Dr. showed, cords and trabeculae, mucoid appearing stoma, as in the cells, the cords and trabeculae floating. And when you do the epithelial mark, you see endometrium का अगर आप respect करोगे, तो CK is completely negative. That is very unusual. And it's not a typically grand forming tumor. It is restricted to the endometrium mostly. From bulk of the tumor will always be in the endometrium. The junction will be very fairly well demarcated. Infiltration, even though on imaging it may show it was not there. That is very good. And most of these tumors, they hardly show any mitosis. So this was unusual. That was the patient closer follow-up, because there are descriptions of malignant uterus surgery. We had in fact one case which was a malignant uterus.
But in that case, it mentioned that there is myometrial infiltration, which you have shown in that image also, that there is myometrial infiltration in that case. In this case, there is no myometrial.
No, not among these cases. There's another case which is not yet published, but it is I think Dr. Anjuba case now. So it was reported as malignant. So that showed clearly very high mitotic activity and infiltration into the yeah. But even that malignant it was still restricted to the lymph. It was a very big one. Easily, yes. Because they are not epithelial cells. They don't have a tendency to infiltrate. Mostly it is benign. This was look more towards the line, but it had some more mitosis than
And the other people people not in the main what in the visual for environment. There's a kind of we are not thinking that that is why it is not but still think because there was high because as usual income this patient should be definitely problem.
We have to design a room.
very.